Welcome to episode 3 of OrthTeam Unplugged. I'm Andy Thomas, founder and director at PhysiQuip, and today I'm delighted to be joined by pain consultant Nick Fraser and spinal neurosurgeon John Leach. Welcome, guys.
Thank you, Andy. That's brilliant.
So I'm going to start with you, Nick. This is particular of interest to me. I played football last night and I have got a little bit of back pain. And that's something which I have quite regularly. I speak to my brother now. We're getting a little bit older. How common is back pain?
Oh, it's really common. Through life, most of us will get back pain at some point. You know, there's 3 really common problems that we see: headache disorder with pain, neck pain, and low back pain is number 3. So most of us will get back pain at some point in our lives. Usually innocent, self-limiting, but yeah, very common. Nothing to worry about usually, and quite easy to treat.
And so what would you say? And I'm not just come here for advice for myself here today, although it might be helpful, but like, I've had it for a little while. When I do some exercise, go for a run, it does feel a bit more sore than normal. But like, at what point do you start to seek a professional?
I think if it's getting better quite quickly and it's normal for you and it's not interfering with any of your activities of daily life, we wouldn't really ask you to worry about it, or take simple advice from a physio, simple painkillers, get some rest, modify your activity, and that should hopefully sort you out. If it's not getting better with simple measures, that's when you can escalate up to someone like myself.
Right. Well, I may come back to you for more advice on that throughout. I'll see how it feels throughout, as long as we sit here for. So for you, John, neurosurgeon, that sounds, I certainly hope that I don't need neurosurgery for what I'm experiencing, but what part do you play in this?
It's interesting that you say that. So I don't think anyone comes to see a spine surgeon wanting to have a spine operation. And that does tend to be at the end of the line of other treatments. Fortunately, and you mentioned back pain, fortunately, lots of conditions in the spine are actually self-limiting. So where I come in is when there are symptoms that might be quite severe, or perhaps they've become chronic, in advising patients, helping them look at imaging, signposting them perhaps to physical therapists, involving pain colleagues. And there are a proportion that, after they've been down that pathway, benefit from surgery. But sometimes physios are surprised to hear that I probably operate on 10 to 15% of patients I see in clinic. I think spine can be quite difficult to work out exactly what's going on. I think it's quite a complex area. You mentioned back pain. So if back pain's become intrusive, say for 3 months, and it is interfering with lifestyle, then patients often come seeking an answer, what's causing it. And we may do imaging. That can be helpful. Imaging can be helpful to provide reassurance. But if imaging is done and there's a report without any explanation, it can actually do the opposite. And imaging findings can concern patients. So I think the first thing is to recognize that spinal pain, back pain or nerve pain, can cause quite a lot of anxiety. And so where I come in, I think, is not just operating, it's actually providing specialist spine advice to people who are anxious about their symptoms.
So how does someone get to see you then? So what is the pathway to see you?
So most often it would be a referral from either a physical practitioner, often a physiotherapist, or actually from another consultant would be the most common pathways. But patients can self-refer, GPs can refer. So there's a wide range of possibilities for access. And of course, these days in the insured market, then there's lots of online or telephone advice, and then patients get signposted to our clinic that way.
Right. So in terms of that then, so I wouldn't say immediately think I need to speak to this John about my back. John Rogers, one of the other sports med consultants. So what would influence them to think that they need to escalate it to, I would imagine that they would think it was more severe to want to speak to you.
So for colleagues who've got a spine problem, particularly sports doctors, then it may be someone whose nerve pain is severe and refractory to normal initial treatment. It may be someone whose nerve pain is associated with a moderate or severe weakness, because that can be a relative indication to intervene. But what we do at OrthTeam is we try and get the patient in front of the right person as quickly as possible. I think sometimes for a referrer, it's a puzzle for them. Do they refer to a surgeon? Do they refer to the pain doctor or to the sports specialist? And one of the issues in private care is many consultants, I think, work in silos, and you send them the patient and then they try and manage it. Whereas what we have at OrthTeam is an MDT approach. We started up the spine MDT in 2020. So it's important that I understand what I can offer the patient, but I also have developed an understanding of what Nick can offer or what our sports consultants can offer. And I'm also keen to talk often to my referrers and understand what physical therapy can offer. Because to help the patient, you've got to understand the sort of full range of potential treatments. So through the MDT approach, I might, or a sports doctor might receive a referral, and we discuss it at our meeting, and we'll agree as a group on what's likely to be the most beneficial treatment, and the patient can be sort of put down that pathway without this situation that sometimes arises where a patient's maybe been under a surgeon, perhaps even pushed towards surgery when other treatments might be better, or another patient who's perhaps been under a non-surgical spine specialist and has actually had pain for a very long time and never been offered a surgical solution. So we're trying to avoid that situation where a patient doesn't have the full benefit of the whole range of spine specialist care.
Yeah, that sounds really interesting. Anything to add to that, Nick?
Yeah, no, I completely agree with everything John's saying, particularly the fact that we work as a team and we're closely linked together. I get a lot of referrals from John. I get referrals from physios, from sports exercise medicine quite commonly. And I know a lot of these people that are referring to me, and they know me, and they know what I would do and how I would handle that patient. So it's very easy for them to refer to me. They're comfortable. The patient's going to get seen quickly, assessed thoroughly. If I have any questions for John, I can just reach back to him. John has a very structured approach, which is very easy to work with. He writes to me, gives me all the information that I need. He tells me about the imaging and the salient points from imaging, summarizes what the MDT has told me. It's really, really helpful. And I get a rapid head start with that particular patient. And I know where the boundaries are. So if there are certain things to look for with a patient, I know when to send back to John. Some patients have to go back to between pain medicine and neurosurgery, back and forth a couple of times till we find the right point for that individual patient. A patient might start with John, then come to me. I'll put them through my catalogue of treatments, get them as good as I can, see what's left. Often we would have improved that patient's pain picture and things might be clearer then. And that might then be different. And John might then be able to see, oh, hang on a minute, there is more nerve pain here than we could see before, because pain can be masked in complex ways. You can only really feel one pain at a time. So if you've got 2 or 3 areas of your body that are causing you pain, you'll really only know about the worst one. And that's part of the brain that switches off those pain signals from those other parts of the body you're not noticing. So we switch pain off in the spine. That's one of the things that pain doctors do. And that might then actually reveal something else will emerge in its place. And that's when a patient might then go back to John, go to a hip surgeon, go to a knee surgeon, go to a sports exercise medicine doctor. And actually that patient will benefit from that more clearly because they're a cleaner case to treat, a simpler case to treat, and get much better outcomes.
What are those techniques that you use to do that, to treat the specific areas?
So I think simplistically, we do 2 different types of procedure. We do procedures for people who have a very new problem. You might have a slip disc and a trapped nerve in your neck or in your low back, and we can pop some steroid painkillers directly onto the source of the pain problem. And that's a really good and simple technique for relieving inflammation, relieving pain. So we do that quite commonly for people who may have had pain for maybe only a week or 2. There's no time is too early really to have a steroid injection in that scenario. Those patients usually would have already been seen by a neurosurgeon, and the neurosurgeon's happy. They don't need to do surgery yet. They're trying to manage the patient non-surgically. As John said, only about 10 to 15% of patients who present as neurosurgeons actually end up being converted to having a surgical procedure. So a lot of those patients will come through pain, and we'll manage them, we'll reduce their pain symptoms, and hopefully the patient will recover. So that's the first group. The second group, a patient with a more chronic pain picture. They've got a long-term debilitating back pain problem. And that's something we can usually assess or treat, because we do have some techniques for selectively switching off nerves in the neck and nerves in the low back that cause that sort of pain. So and this is all very simple. We do some diagnostic blocks to just temporarily numb the area and see what changes. So if you have a lot of neck pain, we switch that pain off you with local anesthetic, which is very simple and safe to do. And your pain goes away. We go, okay, we now know where the source of the pain is. We can bring you back, and we can now turn those nerves off for about a year or so using some of our neuroablative techniques, which again, very simple, low risk, end of a very, very clever needle that allows us to deploy a heat or a cold lesion over the nerve. And it basically just stuns the nerve for about a year or so and slows down transmission of pain signals to the brain. So that's what we do every week at the OrthTeam Centre. And we get good results. So it's fun to do.
Yeah, I mean, it sounds absolutely amazing. Like, it's really interesting to hear it. Like, how have techniques changed in that area over the last few years?
I think, well, these techniques, the neuroablative techniques, were invented in the States in the 70s. There was back pain was a problem that they couldn't treat, and there was a surgeon who had an enthusiasm for anatomy who said there must be nerves in the spine that are causing these patients all this pain. So they did a lot of studies on patients, and they found these nerves, and then they started freezing them using liquid nitrogen. Liquid nitrogen is very, very cold, causes quite a lot of harm. So they then developed other techniques that are not as cold, and we use cold lesions down to -80, which is very safe and simple to use. And we use heat lesions, which again goes up to +80 degrees C. And we can range between them as we feel appropriate for the target that we're treating. So we've got some really good kit now that allow us to do this. The kit's improved amazingly over the years. And we have access to a wide range of really advanced kit now in the OrthTeam Centre. And at the moment, there's a big rise in these techniques generally across the NHS and the private sector. But I think you need to be quite enthusiastic and do a lot of these cases to get good at them. So the techniques, whilst they're relatively simple, it's not until you've done a certain number that you become competent. And certainly I've done so many now. I'm definitely a lot better than when I started. And that counts for a lot, really. The number of cases that you're doing increases your the safety and improves your outcomes. And you can you know when to tailor the treatment for an individual patient's need. So and we do that a lot. Some people need more treatment. Some people just need a really subtle amount of treatment just to work, really. And it's nice to be able to have a handle on that, have that sixth sense, and you know where you're going with an individual patient. Equally, I know when not to do it. So some patients will present and I'll know I shouldn't be advising anything for this patient. There may be a medical reason that would be a reason why you shouldn't do it. There may be a physical reason. There may be a concern that you might make the patient worse, or you may put the patient through a procedure that wouldn't work. And it's very important if you not to do procedures that are going to fail. You want your failure rate to be as low as possible. Does that make sense?
Yeah, it does. No, that's really, really interesting. And then also on your side, John, how have the techniques changed over the time that you've been working in this area? And also I'm intrigued to know about that percentage. Has that fluctuated throughout your career? Are they like industry standards in terms of the number of people you operate on?
In terms of the numbers of patients you operate on, there's not an industry standard, and it will depend in part on what your referral base is like, of course. But I don't think overall it's changed, other than to say that the more experience you get, you tend to intervene a bit less. So I think it's true of all surgery. When you're younger, you're a bit more enthusiastic, and perhaps less understanding of the nuance of who to leave alone and who not to operate on. Most people understandably think that the real skill in being a neurosurgeon is the surgery, but like any part of medicine, the actual real skill is in clinic and understanding who to operate on and who not to operate on, because the techniques we're doing all the time. So once you're trained, you don't find that too stressful. There's been lots of changes since I trained. There's a massive implant industry in spine, which is something that drove me towards spinal surgery rather than brain surgery, to be honest. Implants are always changing, they're always improving. That's fantastic, but it comes with its own little dangers of industry pushing new gear. And you've got to make your own evaluation of what's really in your patient's interest and what isn't. So there's that dynamic with industry, which is exciting, but you also have to exercise caution. So we look at our implants, we're now putting in percutaneous screws routinely, whereas in the old days you'd make a big incision and cause some pain. These days we've got the technology of navigation platforms, navigated surgery, percutaneous implants. So it's absolutely fantastic compared to the surgery of only 15 years ago. We also have much more monitoring technology in theatre. So we can do intraoperative spinal cord monitoring or nerve monitoring. All of these things are designed to minimize even further the rare risk of a neurological problem in surgery. And of course, that's every patient's and surgeon's number one goal, as Nick alluded to. Don't have a treatment that fails, not making someone worse. That is very unusual, but taking cues from the airline industry, we don't want it to be 98% okay. We want it to be 99.9% okay. So there's been lots of changes in technology in that regard. The philosophy's changed as well. Everything is now about being less invasive and doing the minimal possible. The philosophy that any tissue that's normal anatomical tissue and doesn't need to be touched, you leave it alone. So we're always trying to do an effective operation, but using tools and techniques that cause the minimum amount of tissue damage. And that has resulted in less post-op pain, quicker recovery, and I think far better surgery for our patients.
In terms of that recovery and rehab, I assume would be a part of both of your works. So how do you interact with the people that are referring into you? So come to you on that, Nick.
Well, I have a lot of referrers, and I'll often speak to them, and they know how to get hold of me, and quite often get a message from, can I have a word with you, and nothing urgent, and then get back on the phone. So we've got very good communication links with physios, with GPs, with neurosurgeons, spinal surgeons, other doctors, sports exercise medicine doctors. So not a week goes by where I've not had a couple of messages and had a couple of conversations with colleagues, and I really value that. You know, you get background on that patient that's really helpful. You have an idea of the timeline that might be the patient needs for treatment. You know about previous treatment responses and response to physio. You know about all the other options that are available to that patient. So you don't feel on your own. You're supported in the care of that patient. And if you get someone who makes the effort to contact you and call you, you really value that. You know the patient's actually had a good pathway to that point. And the patients normally arrive well informed, knowing what to expect. And as John was alluding to earlier, anxiety is a big problem for all doctors, but particularly pain doctors. So there's a much higher incidence of pain in patients with anxiety, and any painful problem is inevitably going to cause anxiety purely through the release of adrenaline. And people will be frightened about coming into a treatment centre and coming in to see doctors and in an unfamiliar place. So we put a lot of effort into making people feel safe and welcome, and we look after them, and we actually actively inquire to make sure they're okay all the way through when they come in for treatment. And patients are always at the end saying, right, that's your procedure done, quite commonly saying, really, is that it? Or, have you started? We've finished. So it's nice because they feel safe and secure, and the team are friendly. I think that's really, really useful. I've gone off your original question really about referrers, but referrers, I know them all really quite well, and like John, and I know that I know what they expect of me, and I know when I need to go back and get back in touch with them, which is really useful.
How about you, John?
Yeah, that's a really interesting point. I mean, I get a lot of referrals from physical therapists, and I like that because at least I know then that there's been a professional looking at the patient in terms of the rehabilitation goals that they need to have afterwards. So I think the natural inclination of any patient is So you have severe nerve pain. You've gone through some other treatments. You come in for surgery. The surgery happens, the nerve pain disappears, and the tendency is, right, I'm done now. I'm off to play golf, or I'm back to work. And actually, as I say to patients, getting them through their unpleasant nerve pain and getting the wound healed is then the beginning of the journey for their rehabilitation. And the reason I like getting patients from physical therapists is prehabilitation is actually really important. So it's important in terms of patient understanding maybe where they're very tight or weak beforehand and what they need to work on. But it's a mindset of, it's not just the operation that's going to make them better. It's the operation, the post-op rehab and their effort in that rehab that's going to end up in the sort of best result at 3 months and 6 months. So relationships with referrers are obviously crucial. Sometimes it's something else completely. So I'll get referred a patient with a spine problem, but actually it's a secondary problem, from the knee or the hip. So if I have a patient that's been passed around different consultants, you begin to think, really, has anyone really assessed the connections, between the spine, the hip, the knee? Who's looking at the overall picture, and often that's a good physiotherapist.
And what happens in those cases then when you do get those patients and you may be thinking, actually, maybe there is some other stuff that needs to be done?
So I will write a letter or phone one of our high referring physios and explain my dilemma. And I'll say, I'm open to seeing them again, but I'd really value your input to see what you think. So I may never hear from that patient again because physical therapy is what they needed, or a couple of months might pass and I get the patient back still with some residual pain, and then I'm more confident in what I'm aiming to treat.
Something that you mentioned earlier on in terms of trying to decide what is suitable for that patient, who you're going to operate on, is that purely down to how they clinically present? Is that the way that they interact with you, personality? Like what are the other criteria that you're looking at?
So having surgery is, I think, a very individual matter. So patients will ask me, what would you do, John, if this was you? And that's a very valid question. But I always qualify my answer by saying, I'm a surgeon and I need to work. So if I had a problem and I couldn't work properly, I'd go straight for the surgery. But that's my own philosophy on and my lifestyle. So surgical consent's a journey where you can maybe get to the point where surgery is one option, and then you have to discuss that option with the patient, the likely benefit, what all the risks are, and they need to go away and have a think about it. Lots of people are not ready to decide straight away. Some are. Others need more time. They come back with questions. My experience is that people don't say immediately yes to surgery, but as time goes on, the pathway for them becomes clear. So once they have all of the relevant information about risk and benefit, what the alternative treatments are, there's usually no rush. There's no rush to decide, but at some point the path for them becomes clear. So we're really here to facilitate giving the patients appropriate healthcare information for them to make a decision, if that makes sense.
Yeah, no, it does. And it's one of the things that I've been involved in this industry for about 20 years, and there may have been back in the day a little bit more of the surgeons do the surgery and the physios, they do the rehab. It's much more joined up approach from the way that you're doing. Do you agree with it that that's changed a lot now?
Yeah, it's massively changed. I think what it is more of a patient-focused approach. I mean, that can sound a bit trite, but yeah, it's not just thinking, I do these operations, I can offer you this. It's more putting what I can offer within the context of the whole field of spine care. I think surgeons are better at understanding that. I think there's been some changes in law that help. It is actually a requirement for us to give patients adequate time and space to consider a decision to operate. It's a requirement for us to discuss alternative treatments, and that's being thrashed out in court, and I think that's a good thing. because there shouldn't be pressure applied one way or the other to a patient. And I think that's actually quite rare now that would happen.
So there can be a lot of fear around the back and the spine, and patients when they're presenting, whether it's through imaging or just general fear around that area. How do you deal with that?
So I get a lot of patients that really don't understand, and this is something John mentioned earlier, patients not misunderstanding or being fearful of the findings on their scan and the medical correspondence that they've received. And often people who might actually be a very good surgical candidate can appear in my clinic because an injection may have been suggested by somebody they know for something that actually they probably might need surgery for. So I see a lot of people, and I can help look at them with my knowledge of neurosurgery from working with neurosurgeons. I can see that actually there's a really good case for surgery here potentially. And I will ask them what they're worried about and try and help them understand the condition and reassure them that neurosurgery is really safe. I mean, I've been working as an anaesthetist for 30 years, and modern surgery is so safe. Modern anesthesia is so safe. And I can reassure people that actually you don't need to worry about this. You're in safe hands. And this is what the surgeon's trying to achieve. I'll show them their scan, and often people really find it helpful to view the images. They can then understand the problem more clearly, and we use spinal models to help demonstrate this is a simple mechanical problem in your spine, and this is how you might fix it. So this is something I do quite a lot. Equally, there might be people I see who I think with my anaesthetic hat, actually, I don't think you're going to be offered surgery because you're quite high risk. And that's quite easy for me to spot. And then I might take them in the other direction and go through their medical history and help them understand their medical problems, and either help them improve their medical condition so they might be fit for surgery, or just kind of sow the seed that you might be managed non-surgically because of your health problems. And done in an empathic way, people feel much less anxious and more comfortable, and they're safety netted. And that can be very therapeutic and helpful for patients on their journey.
Yeah, I think it is. It's an area, and I'm dealing with clinicians a lot of the time as well. And I think there's still that fear and anxiety for clinicians as well around this area. So how do you interact to help the clinician and as well as the patients?
Yes, I think there's an understanding that the spine is a very important part of your body. When you start talking about weakness or paralysis or bowel and bladder function, then clearly that's quite emotive. Although neurological risks of spine intervention are very low, they're not zero. And we're not used to thinking about risk. So when you're suddenly confronted with a spine issue, say you're a patient, and then you're offered operative intervention, you actually are required to think about risk in perhaps a way you don't think about it if you go down a ski slope or go out for a few drinks. And I understand that takes time for people to get their head around it. And also everyone's attitude to risk is a little different. For every person that may say, I'm sick of this pain, just get rid of it, doctor, whatever you say will do it quickest, there'll be someone else who might say, I'm very anxious and fearful that a rare complication could happen, and I'm going to try everything else and wait. And there's not a right and wrong answer there. So it's just the understanding that the potential complications of spine surgery can cause anxiety, and help the patient through that and come to the decision that's right for them.
Yeah, absolutely. And another thing, I'm getting back to my personal issues here, but this is actually for my dad. So my dad's had sciatica, had loads of pain, seems to be okay now. Like, he's in his late 70s, still plays football, still does dancing, plays tennis. So very active. Yeah. But he can often have various ailments, and sciatica being one of them. So what is sciatica?
Sciatica is leg pain. It's neurological leg pain caused usually by some irritation or damage to one of the nerve roots that supplies the leg. That's what we would call sciatica. Sciatica is a term that's used synonymously with lots of different causes of pain. It's poorly understood, poorly defined. But to someone like John and myself, we have a clear concept in our head as to what the causes of sciatica are. And if someone has leg pain, we'll want to know, is this caused from a trapped nerve in the spine, or is there another cause going on? So lots of people get sciatica that can, from time to time, play up. And often that's where someone like me, if it's something that's going to be self-limiting, and most cases of sciatica are self-limiting, that means they're going to get better within a few weeks. Then you just want to do some symptomatic treatment for that time, which might be simple painkillers, might be rest, might be physiotherapy, might be a steroid injection, might include a scan, might include a trip to see John. But we hope you're going to get better, and we'll try hard not to escalate you all the way up to surgery. So it's kind of a staircase of treatment. You start with the simple things, and then you go up step by step until you get a response from the patient. Seeing the patient, reassuring the patient, giving them some parameters whereby, okay, let's see how you are in the next week or two, and if things are improving, because I think they will, can often reassure them, and then that can help with recovery. Patients can become quite anxious and stuck in the moment, particularly if that pain is stopping them doing something that they need to do. It might be caring for their partner. It might be engaging in competitive sport. It might be going to work as a surgeon. So the impact is different from all of us. Some people are fine to just park up for a bit and rest and wait for it to get better naturally. So everybody's different. And as John said, we'll take each case as we find them, and seeing the patient, talking to them is really useful. And previous episodes of self-limiting sciatica would normally be reassuring that this is going to flare up for a few weeks and then hopefully just settle of its own accord. That's quite common. Does that answer?
Yeah, no, it does. No, it does,
The aging spine is an interesting one, if your dad doesn't mind me calling it that. So as you're getting to 70 and older, you're going to begin to draw in, less likely that it's an acute disc prolapse, more likely that it's a bit of arthritis, some spinal stenosis, perhaps even a synovial cyst. So you see a patient like that, you begin to think that perhaps it's more the sort of degenerative arthritic side of things than the acute disc. But whilst the pathology might be a little different, the treatment philosophy would be the same. So, for example, if you have a tight lateral recess stenosis and nerve root compression, you might get a bout of pain, and it could last for 3 months. It may require Nick's input, the sort of fast-track injection, but it will often settle, even though the scan's the same and still shows compression. So another thing we do is we make very sure that we don't operate on the scan finding. We operate on the patient.
Yeah, I think that's quite a consistent theme. So we're quite heavily involved in imaging in my other line of work, and there can be that thing now. We want to go for a scan, you go for this, and it's quite accessible for people now. So what role do you guys play in ensuring that a scan is done? Like a patient may request it, but then how do you balance that?
So a lot of patients will arrive with their own scans that they've had done in the NHS, or they commission themselves, or another provider has arranged for them. And we'll want to see the scans, get them imported onto our system, review them ourselves, look at the patient, examine the patient, make an assessment of the patient, and then correlate that with what we see on the scan and the past history. The scans will come with a report, and sometimes we have access to the report, sometimes we don't. We have access to some of our own radiologists who will give us the kind of report that we need. So most radiological reports are standardized, and that can be confusing because it can show things that actually are not active or causing any problems at the moment, so-called red herrings, but actually the thing that is causing the pain may not even be mentioned in the report. So there's a lot of interpretation of scans, and we have our multidisciplinary team meeting, which is just for these sorts of cases, where someone like myself might bring a patient, present the case to the team. The images come up on screen. We've got our radiologists, we've got our neurosurgeons. We all look at the case, we all look at the scans, and we make a decision. Okay, that's reassuring, or we might need to do this, or we might need to do that, and we make a plan. But imaging is really useful, but it's always contextual and has to be looked at in conjunction with the patient's history and examination findings. But yeah, I mean, imaging, we're doing more and more, and we might want to image the patient again, maybe a few weeks later. We might need more imaging if things have changed. Does that make sense? And the idea, and often you'll do imaging to rule out surgery, or you might do imaging to work out what surgery is needed. And that's something I'm sure John would be able to explain.
Yeah, I think you've highlighted a really interesting problem we have in healthcare at the moment. So I'm all for greater access to imaging. I think that's good, but it comes with its own problems, and it's about the way scans are reported and patient access to their reports. So if a patient commissions a scan, you can self pay for a scan now, no problem, an MRI. And you get the report. What do you do with that information, that very medical A4 page of abnormalities? So it's very, and I do see lots of patients with back pain without nerve pain. And I actually find that quite a rewarding part of my practice, because there's lots of people with back pain and high levels of anxiety, particularly after reading their own report, and just trying to put that report in some context for them, make them understand that disc degenerative disease might be a normal scan for someone their age, that it doesn't mean that they're going to have a bad back forever, and it doesn't mean they're going to be functionally impaired. And I think we've worked out yet how we're going to solve this issue, that access to scans is improving, but we're still reporting scans as if it's a consultant that's requested the scan, and the radiologist is talking in their report back to the referring consultant. The reports ignore the patient, and that's actually creating a bit of a problem.
Yeah, I mean, you can tell with both of you, you're both very patient-centered, so I'm sure you guys will figure out the best way to do that bit. And we touched on, it was a radiology one with Andy and Shub last time, and we touched on AI, and in imaging, AI is pretty advanced. There's some really clear paths forward within that. In your work, what impact is AI having?
Well, I don't really disappoint you. I'm sure in radiology it's very relevant, but in pain medicine, not so much really. We use AI a lot for our clinic correspondence and communications, and that's really helpful. When patients come to see me, I switch on my AI medical scribe. I ask the patient, let them know when they arrive, starts listening in, generates notes. It hears everything. I miss things. I don't have the best hearing, but it all ends up in the letter. Really good way of generating letters that are templated and sent out. And for me, that's been a massive boon in practice, because it allows me more patient focus when I'm in the room. I'm no longer having to scribble notes. I'm not typing into the computer. I can look at my patient and I spot more things. I see their behavior. I see things that make them anxious. I watch their movement. And I'm actually spotting more things now because I'm hands-free, as it were, when I'm in clinic. So that's been a great leap forward for me. A lot of doctors are doing this, not just doctors, but physios and other practitioners. And I think they'd all share that opinion, really. So for me, that's been the biggest leap forward of AI. In terms of my practice and use of imaging and the interventions I do, it's not really reached me yet. And I can't see an obvious application yet. But I won't be replaced by the robots just yet.
Let's see. How about you, John?
I just think it's going to be absolutely transformative. At the moment, we're just nibbling at the edges. So, yes, AI for clinics has been brilliant. I'm able to let my secretary, who's now 60, go part-time, because she's actually well ahead of all her work, because AI is doing a lot of the stuff that she used to do. But that's not really what AI is going to do for us. We use navigation at the moment, but some centres use robotics, which is only a slight further step forwards. But very soon you could see that once you have a pre-op scan, say for a long fusion operation, AI could understand and learn where all the screws are meant to go, do the planning, and have everything set up for you with a push of one button. You'd still need to be there in a supervisory context, and obviously for the actual implantation, but it's going to transform surgical planning in complex cases. Agentic AI is only just starting, but why couldn't we just plug into a medical AI, a spine AI expert, and the patient could do a consultation with an AI system and form their own opinions, and then maybe go and seek the treatment they've decided on after that. So I think it's going to really disrupt our whole clinic-based system, to be honest. So I'll be watching with interest over the next 10 years to see how it transforms healthcare.
You've both mentioned about, like, you're both advanced in terms of the new techniques in pain management, and in your side from implants and various other things. How do you keep on top of what's happening in industry?
Well, they come to see us. We go to conferences. We've got strong links with colleagues and go to international conferences every year and meet the leaders in the field. And I know these people now, so I can sit down to dinner and speak to them and share ideas. And some brilliant minds, really, with incredible knowledge and experience, who are in pain medicine, really good communicators, and will, quite happily share their opinions. And it can get quite heated in terms of debate, but everyone ends up at the same point. So it's really useful. Plus accessing the journals and research. But mostly it's through contact with colleagues who are doing these techniques, and the opportunities to go and meet them and learn from them, which is something I enjoy doing.
Yeah, absolutely. Mainly it's through academic meetings, either national or international. And the spine industry is always throwing out new ideas and new concepts of how to incorporate all the different technologies into one small theatre space. It's ever evolving. And that's an enjoyable part of the job, actually. The fact that the way I do an operation now is quite different from how it was 5 years ago. And I think that change will only accelerate.
And in terms of a closing message for the referrers, what would that be?
I think the message I'd have for referrers is I'm fine to see someone for advice. That sending them to a spinal neurosurgeon doesn't mean they're going to have an operation, but I'm there to help them offer the patient a full range of potential treatments for their ailment.
You, Nick?
Yeah, absolutely concur with that. So patients that come through are not going to get automatically be offered treatment. I think that does happen in medicine. As John said earlier, a lot of consultants are siloed. And if you feel that you're clinically unsupported and a patient has 2 or 3 problems, you'll feel responsible for all of those problems, and you'll try and tackle all of those problems. No one can be good at everything. So if you're part of a team, you can send patients out to different people. So if a patient comes to me and they don't need me, or they need someone else, then I know who those people are and I'll send them on. Equally, I won't necessarily start patient on medication that the referrer may be concerned about. And I won't be doing interventions if I don't think it's needed. So, yeah.
Yeah, no, it's great. Look, I've really enjoyed it, and you both speak with such passion about the area. I hope I don't have to come and see either one of you in a professional capacity, but if I did, I'd be very happy to do so. So thank you very much for your time.
Thank you, Andy.
Nick, thank you, John.
Don't worry, I'll use one of the sharp knives.
Thank you very much for that.
Brilliant.
Yeah, so that brings a close to the 3rd episode of OrthTeam Unplugged, and we look forward to seeing you on the next episode.